within the time frame, it's very tough to get a very complicated or complicated enough case and get it done in 10 minutes and get a variety covering the whole domain.
Are you preparing for the recorded consultation assessment? Then this is the right video for you. Today we have Dr. Thuva Amuthan, who has recently passed his RCA. In this video we dissect the RCA. Dr. Thuva shares his insights, his strategies, how he prepared for the RCA, what was he doing to select the cases, how he struck the balance between finding challenging case, managing to complete it within 10-minute time constraint.
Today we're going to discuss the RCA. You've just passed your RCA recently, so you can give us some insights. Could you introduce yourself to people who've not seen you before?
Hi, yes, thank you. Yeah, thankfully just passed the RCA and glad that, obviously CCTing. So my name is Thuva. I'm the Regional Council Member for BMA in West Midlands, as well as one of the AIT representatives from the region. And I have been helping from the start with, COVID in terms of what putting in these alternative assessments, and I've been involved in the AIT community from the get-go, really. And it was what we asked for in some ways, in that we wanted some way to get CCT, but it was still nevertheless until the end, and until even today has a lot of uncertainty attached to it. So it's been overall a very stressful situation for trainees, but I'm glad to be at the end of it, and hopefully all you guys will follow as well soon.
How did you approach the RCA, Thuva?
Well, initially, we all thought, oh my God, it's going to be so much easier, right? Because you're in control, it's recording, and it's going to be so much easier. But then you realize that no, actually, it's much tougher, because patients aren't as adherent to the script as an actor would be. So there's so many variabilities and so many variables they have to factor in. So the way I approached it was literally seeing as many patients as possible, but then you have to be very careful about what you do, and you have to have the whole practice team on board. So I asked them, and they were thankfully agreeable, and I'm grateful for that, to not book any reviews, no meds reviews, no follow-ups, no blood tests with me. It was purely first contact problems only that I was seeing. And what I also did was, you can only advise people so much. They don't know what you need exactly, because we didn't either. What they were looking for initially. 1 week into the period is when the guidance was released. So that changed all the dynamics, because the guidance technically said you had to bring in every other patient you were consulting, whereas practically we weren't doing that. We were being very pragmatic and avoiding contact. But if you look at the RCGP guidance, it said essentially bring every single patient you see in, even if you're sending them to A&E. It said essentially to bring them in for your assessment before sending off. So, there was a little bit of making sure that you did what they asked for rather than what you would do realistically as well. So what I did as well, I think the most helpful thing that one of my colleagues actually told me to do was I got in half an hour earlier, looked up all my appointments and make sure that they were appropriate cases for RCA. If not, what I did was I went through all of my colleagues' slots as well, and I swapped patients around. If I find a good case of that my colleague has been booked in for, and it wasn't a follow-up, I would just move one of my cases that wasn't as good across to them and swap them around to make sure that I had a good plethora of cases, and I knew what cases I had before I started the day, so that I had whatever it is, 24 or 25 good cases that I was going to have a good opportunity to get a good case out of for the day. I think that was the biggest thing I did. That was helpful.
You actually came in early, and you made sure that your team was aware about the selection of cases that was suitable for the RCA. So in terms of how you were recording then, could you tell us how were you set up for the recording?
Just to add to that, the half an hour, I think the time extra that was taken is because what we did, I think everyone did, was, if you got a case, what you did, you opened up CKS, you opened up the VNF, and you had everything ready, and you read through the notes more so than you would usually. Usually you'd go straight in and, let the patient tell you. But here you had to prepare, because there was some element of performance anxiety and making sure the management plan was there. So what would usually take you 10 minutes probably took you more than half an hour to do one callback, because you wanted to get it absolutely spot on. So I think that's what took the time, rather than just, juggling patients around. But yeah, so to the question of how did I record it? Initially, I think the college was very flexible or didn't give us guidance as to how to do it. So we started off doing on our phones and making sure, it wasn't uploading any cloud or anything, and consenting the patient appropriately. So that's how we started off. But then, very soon in, the 14 Fish platform came along, and I found that the best. I just, I didn't want any other hassles, trying to get consenting extra, consenting at the end and all those things. So I just stuck to the 14 Fish platform. Now, saying that, we did have at that point the luxury of having unlimited minutes to record, which is changed now, isn't it? You can get up to 800 minutes that from your study budget now. So that, I guess you have to factor that in now, whereas we didn't have to factor that in. So that was a luxury we had.
Tell me a little bit about how you manage this time constraint of 10 minutes, Thuva.
This is something I've always struggled with. I think everyone struggles with that in practical terms. No one ever manages 10 minutes with complex cases, because as you know, the case GPs are seeing and getting more and more complicated as the allied healthcare professionals coming into the primary care. Now, I think it's similar rules to CSA, really. CSA, the golden 7-minute rule, isn't it? If you're 7 minutes, move on. If you whatever you've done, just move on to the management plan, because 3 minutes is not enough to do a good management plan to begin with. With the RCA, I felt that we had to probably start a little earlier, more towards the 5 minutes, because, the patients, like I say again, aren't as fixed as actors are. Actors are trained to, stick to the script and whatnot, whereas patients are a bit more variable. So I tried to get as many information as possible. And in most cases, you ended up bringing patients in anyway. So there was, not much you could do more past the 5 minutes, but, you can get them. They do talk for a lot longer than that. But so 5 minutes point, I started planning for my management plan. I let them round up. I was running up the cases. So by 7 minutes, I was starting with the management plan. And management plan, you have to be very creative in some way, because of the RCA and the different environment altogether that pandemic has brought us in. So initially, what I started off saying was, about how am I going to bring you in things and things like that. But one of the biggest hurdles I found was people who got caught by trying to explain where to come, what time, what appointment, where to collect the scripts. So what I did was, eventually I learned to nip all of that in the bud with one quick sentence. Well, all I said was, it sounds like I need to bring you in. What I will do is I'll get my receptionist team or one of my administrative teams to give you a call back with an appointment as where to come and how to get your script and things like that. So that meant the patient's question was answered. They wouldn't pose that question and disturb your management plan later on, because you've already answered that question and they're expecting a call back. Any questions they have, they can do that. So there's less chances of interrupting your management plan. And then with the management plan, what I did was, again, it's about giving them options, just as you would in the CSA, the differentials. For example, if you take an ear, for example, it could be, just a bit of wax in your ears, the most commonly caused, or it could be a bit of, external inflammation in your ear, otitis externa, that, you might just need a bit of antibiotic spray for to help you settle. Whereas, if I do examine you, which is the reason I'm bringing you in, and find that, your insides are a bit more inflamed and they might be actually inside your ear, the infection, I might have to give you some antibiotics. And there's a few other things I want to make sure that, it's not spread anywhere else, to make sure I don't need you, to get you to see a specialist today, just to reassure us, really. So that's sort of thing. It's very similar to CSA, sort of full-rounded thing. But here you're explaining a lot more, because you haven't narrowed your diagnosis down. In the CSA, you would know what the diagnosis is. It's just one thing you have to explain. Whereas here you have to explain the management plan for 3, 4, 5 different potential differentials. And then go back and then make sure they still get the option to ask the questions. Are you happy with that? How are you going to get here? The logistics is is key here. In the CSA is not so key, but here is going to be key. Who's going to bring you in? If someone's got, suspected TIA or, vertigo, you're not going to get them to drive. You have to be like, are you safe to drive? You're not. I don't want you to drive. Actually, could your, I don't know, your parents or your partner bring you in? Would that be okay? And things like that. And then especially with the red cases, you're going to be like, actually, you know what? I want you to see my colleague across the other side, because, you've had symptoms and we're just being extra cautious. So there's a lot more to explain in management. So I think you need a lot more time for the RCA in management than you did for the CSA.
We've covered management, so there are 2 other domains, the data gathering and the interpersonal skill. In terms of data gathering, how did you actually make sure that you were scoring high on this?
I think we always underestimate ourselves in data gathering, and I don't think many of us ever fail on data gathering. Even if you look at the CSA results, I think with the data gathering, I think the biggest mistake you can make is forgoing the interpersonal skills. You've got to prioritize that. I think that's one of the biggest lessons I learned from Dr. Guillaume is let the story and let the patient come out with the story, because I think that's the biggest hurdle to failing the CSA and the RCA is losing that interpersonal skills. Because once you lost the interpersonal skills, then you lose marks on data gathering, then you lose mark on management because you've lost the whole report. I think that's the key thing. Data gathering, really the must-dos you must do are the red flags. If you've done the red flags, you've got some sort of history to give yourself a differential, I think that's all you need for the data gathering. And, we've been in practice for 5 years now at least, and our data gathering skills are pretty, I would say, must be good enough for us to get us at least 2 marks, if not 3, in data gathering by this point. So my advice would be, don't worry about it. Concentrate on your interpersonal skills. Make sure the story comes out. And then, go in with the direct question for the red flags, and then wrap up quick time before you start the management.
There are some questions that can be asked out of context. For example, smoking and cigarette and things like that. So, were there any advice would you give people how to ask this question, make sure that they're covering the appropriate psychosocial?
Yeah, see, this is one of the mistakes I made as well, is not signposting. I think that's your biggest friend. If you signpost, you just tick off all the interpersonal skills. If a patient makes a comment, make sure you don't dismiss it and ask the next question, especially, like smoking and things, which could be irrelevant to the context. So if for example, say, doctor, it's been a tough time. And, just something as simple as saying, no, I can understand that. I think it's been difficult for everyone. Actually, thanks for coming to me. Actually, I've got a few more questions to ask just to get a bigger rounded picture and, well-rounded picture and understand your whole context, and to make sure that we're not missing anything else. Is that okay with you? And the patient will say yes. And then that will flow naturally. Whereas if you just bust in after the patient said it's been a tough time, doctor, with, do you smoke? It's going to be difficult. Because there again, you can relate the smoking. Has it actually gone up because you're a bit more stressed? So you tend to smoke a little bit more, or drink a little bit more. So you can tie those in. So reacting, I think, is the important thing. React before you ask the next question. Don't ask the question without reacting to the last comment from the patient.
So it's important to actually making sure that the things that the patient was telling us, we're using that to integrate into our consultation, not just asking it for the sake of ticking a box there.
Absolutely, yeah. Respond to the cue.
One of the things that's challenging in the RCA is to get a case that's of high challenge, but at the same time to making sure that one can complete it within 10 minutes. How do you find this balance?
I think this is a difficult balance, and this is my personal opinion. I think to some extent, within the time frame, it's very tough to get a very complicated or complicated enough case and get it done in 10 minutes and get a variety covering all the domains. I think you can only do the best you can do. My strategy was I did all the cases I can do, and I tried to do as best as I can and tick all the boxes. And do remember, it says we encourage that you have a widespread cases across the domains. It doesn't say you must. Okay, sometimes we get too hung up on those things, and that especially our IMG colleagues get too hung up on these things. And if I had a reasonable, let's say a reasonable mental health case and a good derm case, and it's going to be the third derm case, whereas it's going to be the single mental health case. Personally, I'd still submit the derm case because I know I've done it and I've not made a mistake. Yeah, it could be simple, but you can't be marked down for not doing something or not having done something well. Whereas if you submit a case just because it said we encourage 2 domains of this for and you submit a mental health case, it's not good. A good case, it could be okay, but it's not a good case. You run the risk. Yes, the examiners have come back saying there's been a lot of low challenge cases, but you've got to factor in we did it under a very, very narrow time frame. We did what we could, and that's all we could, because the risk with taking a complicated case on is that first, if your patient is good, then you might be able to do a good job in that time. the patient is a difficult patient, there's some language barriers and there's multiple complexities, then one, the rapport isn't going to be there, so you're going to lose your interpersonal marks. And do you really want to run the risk of that? It's a difficult question. And two, you're not going to finish in time. If you're not going to finish in time, you're not going to score the marks. So it's a balancing act. You've got to balance it out. Do you take that complex case and not get the marks, or do you take something that's not as complex but score the marks? I personally, I'd still take a 6 case, a moderately simple case that will score me at least above average mark, than a complicated case that where I risk losing marks. However, saying that, then it is true, with a complicated case, there is more likely that you will demonstrate interpersonal skills, a better management strategy, because it's not so straightforward. It's not like, it's going to be antibiotics drops and, if it's wax, just stick with it. Whereas, for example, chronic pain or something, you could be a lot more personable. You could say, I can see that you're in pain, and you can show a lot more rapport and empathy in that case. So I think it's case by case, really. I would do the case, and what I did was I did all my cases. I didn't, which is a mistake. I think I didn't go through them throughout the time. At the end, I went through and listened to all the cases, and I scored them out of 9. Okay, and I picked the cases I thought I scored bestest. I didn't care how complex they were. If it was too simple, like a mole that you're fast tracking, unless you could chuck in things like, are you wearing sun cream? Is there a family history of it? And things like that, and make it complicated. You remember, you can make simple cases complicated by going into the social elements and, checking on the patient and, and exploring how it's been affecting and things like that. It's the way you do it that makes a case simple or complex, not what the problem is.
What do you think that some of the trainees might be wasting time on in terms of when they're collecting these cases to submit? What would you say people waste time
on? I think wasting time on was, for myself personally, when you're 3 minutes in and the case isn't going well, sometimes you just abandon, because there is burnout. That's something that hit me really hard, especially on the Friday before submission. I was really, really stressed out, because doing this case, as you would by the book, takes a lot out of you. Whereas in general practice, on a day-to-day basis, you can be pragmatic. You can come to solutions very quickly, and you may not need the 10 minutes for some cases, which means you save some time and energy for the other cases, which take more out of you. Whereas if you're doing 24 cases, full hands in, full effort in, and with all it takes, it wears you down. Every day, if you ask all the people that's recording that, they will tell you, you come home and you have no more to give, because you're giving every case 100%. So that's why you have to be strategic. If you think a case is not recoverable, stop, do it pragmatically as you would on a daily basis, and move on to the next case. And now that could be 2 reasons. One, it could be someone who's just calling up for a repeat prescription and, the slot's just been wasted. That's fine. Call it, do it, and move on. Or it could be the patient, your report's gone out the window. The patient is angry. It's going to put a complicated complaint against you, not because of any of your own fault, and you're not able to use that case. Of course, an angry patient is a case you can use, but if you sense that you're not going to be able to, console them and get a good result at the end, then just be pragmatic and do what you would do and move on, because, you have to conserve your energy.
Absolutely. If you had to take it again, what would you have done differently?
That's a very interesting question. What would I have differently? I think I would have worried less about clinical management. In terms of the actual management, in terms of the medication therapies, and worried more about the interpersonal skills and what I was saying in my management and how I was going about it, because it got me quite stressed out. I was checking CKS before every phone call and trying to go through all of it. I think that that takes a toll on you as well. I think I'd worry less about it. I think it's probably one of the best things I'd say. Really.
How are you actually managing in terms of the numbers? How many good cases you get per day or per week? What would you say training should be aiming for, Thuva?
So the recording time frame is 10 days, isn't it? Or submission time frame is 10 days, isn't it? 2 weeks, and you get 2 weeks beforehand, so it's about 20 days. So I would say if you get a single good case per day, you're doing well. Yeah. If you get a good case and an average case today, that's even better. Yeah. There will be days you will have nothing. Don't despair. It's hard. It's very hard. But there will be days where you have nothing. And the important thing is you got to remember it's tomorrow. Keep going. So it's a stamina. That's what it comes down to.
Did you get any support with this exam?
Oh, just one more thing. Do remember, when you start out, your cases will be not great. It will take you 2 weeks until you iron out things like, wasting time with appointment times and where to go and scripts and stuff. You initially clock onto that very quickly and you will strategize. And eventually, within the 2 weeks, you will iron out those simple errors. So do factor that in. So give yourself like a week just to do it as a dry run where you're record it, but you're not going to get good cases because they're going to be like logistical errors you're going to make, which you'll iron out. Support-wise, I think that's a very difficult question. Being the first cohort to do it, I think no one had a clue what was going on. The TPDs didn't have the clue. The examiners themselves didn't have a clue what they were marking against because, the guidance came out, like I said, a week into our submission period. So it was a big shocker. But thankfully, you guys have something to refer to. We've got our marking feedback, which is limited, but there is some feedback that you can use. So that's good. So in terms of support, I think there was mixed support and a huge disparity up and down the country, which is always unfair, but it happens. You can't do nothing about it. There were TPDs up and down the country who were going through every case you were submitting and giving them advice. There was, unfortunately, in our locally, the TPDs even told us, you're not to listen to any of the cases. All you're doing is signing it off. So there's a huge variety. Personally, we didn't get any support at all in our BTS. But hey, there have been BTSs where the TPD has been hands-on, going through the cases. But I definitely think someone else listening to your case is a very important thing you must do. I know Dr. Gyam listened to couple of my cases on the course, and it was very insightful because they pick up on things that were obvious that you wouldn't pick up on, or things that you do pick up on, but you just don't think you don't give them as importance as you must do. There's crucial things that they will pick up on, or even your colleagues. What I did was we stuck in our study groups, all three of us listened to all three of our cases and marked them. That's how we pick the submission cases. Yes, we all have different opinions, but it gives you a benchmark. You need to benchmark against someone else to be able to know what's good and what's not good. Without that, you're going blind. It's an impossible thing. I wouldn't advise that. You must benchmark with someone else, whether that's your supervisor, TPD, or colleague.
Yeah, that's some very sound advice. Absolutely. I think it's important that you get others' perspectives, especially if you're looking at your own consultation. You might be biased and subjective and have some blind spots. So having somebody else's perspective on it really helps. And then in the end, you choose which one you actually want to submit.
That's right. Yeah. I would say I had about 8 good cases or 7 or something like that. And I had 6 average cases. So you will come there, but that was better than having, all of them being average.
Absolutely. Well, thank you very much for taking the time today, Thuva. And I wish you all the best for the future career.
I hope you found this video useful. Smash the like button if you found this video valuable. And don't forget to subscribe for new video every Thursday. Take care everybody. Bye bye.